to thank the organisers for asking me to give this talk. I'm not sure what they were expecting from me, but if it was just wire skills, I think we could finish this in 2 minutes and go. So I've taken a bit of a latitude in the actual title here. And I thought, as I was thinking about this, what does this mean, for us as surgeons, and with TAVI and other percutaneous technologies coming around? I think we need to get away from being so territorial about procedures themselves and think about it from a patient perspective, think about disease processes, and think about the whole sort of thing that we can offer as well within the sort of new structural heart treatment management that's happening. So I certainly think that it's important to look at that. And for my part, my reflection sort of goes back from a personal experience of being involved in TAVI since 2007. I've done around 500 cases, majority of them actually transfemoral. The only approach I haven't done is actually carotid, but we've done everything else. And whilst I'm going to talk today about what I have learned, I can tell you that, when you go into the catheter lab as a surgeon, there are things the catheter lab can learn from us. But I'm not going to talk about that, all sort of WHO checklist and sort of perhaps issues around sterility and masks and all of that sort of stuff. But I'm going to talk about what we can take away. I think the first thing you learn about catheter labs and the way they run their lists, particularly from a surgical perspective, is it looks like chaos. I mean, if you stand outside the lab, 3 or 4 labs, and you can see how they're running it, there is a lot of running around being done by staff, by registrars, by nursing staff. Yet, what I see is this absolute will to get the work done. There's no one going around saying, oh, well, we haven't got the serum rhubarb, so we're going to cancel the case. Okay, people work around, they find the serum rhubarb and they get it, and they get the, things that we don't find comforting as surgeons, people being consented on trolleys in corridors and all that sort of stuff, but they do it and, they get good results from it. Now, obviously, their procedures are different to ours, but I think there is a theme and something that we can take away from this. I think they work differently to us. Some of it good, some of it not so good, but I do think one of the things that they do very well is they do a lot more generic working. The roles of the staff are not so intransigent. And within the actual catheter lab, people are aware of other staff members. If somebody leaves, somebody's aware someone's left, and so if somebody gets asked, that role gets picked up. There is no sort of requesting staff to do something. I mean, I don't know the number of times you have sort of, ask if the scrub nurse leaves, the ODP needs to sort of make a special request, could you open a packet of sutures? Whereas in cath labs, it just seems to happen. And there's certainly less playtime available for catheter staff to sort of get on computers and mobile phones and do things as they are in the operating theatre. I think when TAVI developed, I was quite impressed with the way the cardiologists, particularly in England and, well, in the UK, how they started to get involved, how they started to support the actual procedure. Now, some of it may be quite selfish, At the moment, TAVI is largely in tertiary specialties. I'm sure those cardiologists who work in DGHs are looking at what's happening with PCI and thinking, well, this will eventually filter out to us. But there is a far greater support for the procedure, both locally and nationally. They certainly get involved with the commissioners. They go to those boring meetings. They attend, they make sure that their procedures eventually get a tariff. There is some money to be made out of the procedures, and they make it happen. They also have far more sort of user groups, probably because there are more of them, but they certainly do there are a lot more meetings, a lot more sort of frank exchanges of techniques, tips, all the sorts of things that, practical things that you and I also find important. The other thing, about this is that, if I look at us and I look at the SCTS and the UK and I see what's coming around, we've had talks on sutureless valves, we've got neocord around, we've got cardioband, we've got harpoon. I don't see any surgical sort of steamroller pushing commissioners into looking for funding for these things. We're sort of sitting there not doing much. I don't think that would happen in cardiology. So those are sort of the generic sort of overall things I've picked up over the last 10 years. Undoubtedly, I've picked up some wire skills. I mean, and there are lots of different wires. I mean, from sort of on the far left, as you look at it, there's sort of standard 035 wire to some super stiff wires to some pre-curved safari wires. So there's a whole range that you need to learn about. And one of the things people ask me is, how can I learn wire skills? Not in cardiac surgery. Okay, you've got to go and find the courses somewhere else. They do exist. There used to be a VIT-C course, which was for cardiologists, cardiac surgeons, interventional radiologists, and vascular surgeons, but that doesn't happen. But there are still other specialties running courses for which you can go and attend and pick up some basic wire skills. These are just two that I randomly Googled on the other day when I was preparing this talk. So it's not hard to find. I mean, if I can find it, any of you can find it. But you do need to think outside the box, okay? It's not going to come from within cardiac surgery per se. The other way to pick up wire skills is just to get involved, okay? Observation as a way of learning seems to have left the current cardiac surgical trainees' book. They don't seem to like to come and watch and just learn from watching, okay? Because it is frustrating, you know, you kind of feel you're wasting your time. And it's time consuming. And if you're a consultant, you need to cancel other clinical activities. I mean, when I started this, I had to cancel my operating list to be in the cath lab. You've got to treat it as work. You are working. You know, just because you're not opening a chest doesn't mean you're not working, but you have to treat it. And as I say, it is a lost skill, you know, in cardiac surgery. Come and learn by watching now. You know, we're doing fewer procedures and they're getting harder, and you learn more from watching somebody do a difficult procedure than you yourself doing a straightforward case, particularly if you're a senior trainee. Now, I think what they wanted me to do is give you some examples of wire skills. I'm going to give you 3 examples of cases in the last few months that I've done. They're not rocket science. They're not something that you perhaps wouldn't have thought of yourself. What I can tell you from this is that my solutions to this just came naturally and very fluidly. I didn't have to think hard. It just happened. And I think that's what you take away when you talk about transferability of skills, is things becoming natural in your day-to-day work. So the first case was a gentleman who needed a redo MBR, huge guy. I mean, he was a big, tall guy with a very deep chest. And he was very stuck down, actually. It took a long time to get in there, but finally got there. And I did want to cannulate the SVC. The nominal I couldn't really find. It was stuck to the aorta, and I didn't want to do any more than I needed to. And I couldn't get the SVC cannula in. I could get it in, but I couldn't get the angle right because it was a deep chest and I had to make a right turn. What I had done was use the Medtronic EOPA cannula. I don't know if you're all familiar with it, but it comes over an introducer. You can put it over a wire. I hadn't put it over a wire, just direct stabbed it in, but it has an introducer, so you can just cannulate that a little bit higher, give yourself a bit more room for a clamp. So I'd use that. So, and you can see it there. There's the EOPA cannula. I didn't have the wire, but what I did do was I took the white introducer, put it into my SVC hole, put a wire up there, took the cannula out and passed a 32 French venous cannula up it. Okay? And it happened in 2 minutes. It wasn't sort of, I knew what I had on the table, I could just do it. Okay? It didn't feel unnatural to do it in theatre. Similarly, we had difficulties. I thought I was more of a technician in this case. This was a 38-year-old woman who'd arrived to us, or to my cardiologist actually, having had 12 hours of chest pain. She had she had Crohn's, that was it. But she came, they took her to the cath lab. She'd had 12 hours of pain, completely occluded LAD. It was a very senior cardiologist who struggled to find an LAD actually on her. We echoed her, the anterior wall was dead, lateral wall had gone, so there wasn't much point taking her to theatre. She had a balloon pump put in, went down to CCU, she had ongoing pain, came back, and cut a long story short, she started to develop cardiogenic shock back in CCU. They did reopen the LAD on the second time because she had a lot more anti-clotting agents. She had a whole shed load of everything that you could think of, but they managed to open up and re-establish flow down the LAD, but it didn't really make an awful lot of difference to her. There were ongoing discussions because she was 38 with somewhere that had proper LVAD support because we don't have it, and the decision was that we could make up an ECMO circuit and then have her retrieved. So on that basis, I took her up and I thought we'll take her to our hybrid theatre. We put under a GA, and I rather quickly got access percutaneously to the femoral vein, and I got the 20 French dilator in before you could say anything. But in the meantime, having been anaesthetized, the on-call anaesthetist at the transplant center came on and rang us, and then we had a bit of a chat from anaesthetist to anaesthetist, and then they felt overall that having been anaesthetized, put on a bit of NORAD, she was, we got a cardiac index above 2. They felt perhaps we didn't need to do our ECMO right now, which left me in a difficult position because I'd got a 20 French dilator up there. And we pressed for about half an hour, it didn't stop bleeding. She'd had a bunch of antiplatelets, 2-3 inhibitors, and tyrosine, everything, and loads of clopidogrel as well, bearing in mind she'd had that thrombosis. So my other worry was that I wasn't quite sure what would happen in the middle of the night. I wasn't on call, but I felt if she went off in the middle of the night and we had to do ECMO at 2 in the morning, having to then get access would be a little bit harder and probably in a more emergent situation than before. So that was my worry. And in the end, what I did was I took a Cook sheath, an 18 French, it's one that we normally put in to sort of put a TAVI up, and I put that in and I left it in there as a sort of tamponading mechanism. And in fact, what eventually happened was that overnight she sort of held her own, and the next morning, it actually wasn't until the afternoon that she then got transferred up. Unfortunately, she's not had to go on ECMO, but she's now on the urgent transplant list, so we'll wait and see what happens there. This third case is not so much of a success. It's a gentleman who was actually turned down for TAVI, and I decided I'd do a mini AVR, but we had poor access and I couldn't get to the RA. So we thought, well, we'll just put a venous pipe in. And it didn't feel quite right to me. I got the guide wire. Before I put it in, I thought, oh, this feels a bit floppy, but it's the one that comes with the kit. And, to be honest, it's also one that I've used before. We got it in, it was seen on the ATOE, we could see it in the RA. So I then passed this cannula, which is a 23-25 French, so part of it's 25 French, the other part's 23. And there was no resistance, but as it went up, the anaesthetist said, oh, we've lost the wire. Okay. And it was pretty clear within about a few minutes that we had an ILAP perforation, at which point I converted it to a full stenotomy. And we did the AVR, but obviously ended up with a laparotomy and needing a repair of his iliacs. Now, I after this talked to my cardiology colleagues, and particularly the EP guys, who put a lot of things into the femoral vein, and big things. And one of the things that seems to have come out here is that, putting a 25 French over a floppy wire is probably not a good idea. Okay, and yet all of our surgical kit has that. We don't have anything else. So it did teach me that we need to think about putting stiff wires into this, but it does raise the issue. You can't just shove a stiff wire up a vessel. You have to put it over through a catheter. So somehow we've got to work out how we're going to do that and how we're going to image that, and whether or not, as we do more minimally access stuff, do we actually need a bit of imaging to do it safely. So what have I learned? Well, it's reinforced that I quite still enjoy doing heart disease and managing heart disease. It is rewarding in many ways. I'm probably more flexible and accommodating than I thought I was. And the one thing that is true is that the more you do, the more you get asked to do and the more you get involved in. So, by starting on the TAVI route, I'm now involved with the mitrals, we're involved with all the transapical stuff that's coming through, got involved with the transcable stuff. So if you don't get involved, then you're never going to get to do anything. Okay? Because some of the basic skills, like as we've just heard, if you want to get involved with the mitral and you're a mitral surgeon, but you've never done a transapical approach, you're going to be already needing a sort of a learning curve that other people have gone past. So I think there are issues for us in surgery. And I don't know if any of you have seen this movie. It's a good movie. It's not a feel-good movie. I mean, you don't come out feeling happy. But I don't see more and more cardiac surgeons getting involved in structural stuff. And it's not because people are keeping us out. It's we're keeping ourselves in. And and we will, I've only been doing it 10, but in the 10 years, I've not seen a huge increase in people aggressively coming to learn to do things, and we're probably making the same errors that the vascular surgeons made and had to relearn. And if we don't learn from them and start working with our structural cardiologists and learning the basic skills somehow, then we're going to keep ourselves penned in, and we will stand still for 50 years. Thank you.